nephrological membrane that equals almost the body's surface area, and that the flow to the peritoneum is maintained even at low mean arterial blood pressure, and that transportation mainly depends on the surface area of the capillaries. This is a simple display of what we are doing during the PD. We instill fluid that stays there or dwells there for a certain period of time and then is drained out, and this cycle is repeated 3 to 4 times a day. For the PGs, these are the principles underlying CAPD: diffusion, ultrafiltration, and absorption. And we all know that diffusion depends on concentration gradient, the surface area, membrane resistance, and of course the size or the molecular weight of the solute. And ultrafiltration, of course, depends on the concentration gradient of osmotic agent, the effective surface area, and very importantly, hydraulic conductance. And then there is the lymphatic reabsorption. Now, there are talks on the PD following this where you will get basically more elaborate statistics, but globally at the moment close to 10% of the population are on some sort of PD. So that is basically the global share at the moment. We have seen over the last decade declining trends in the developed world, but there's been dramatic surge in the PD related activity in India, China, many of the emerging economies. And this is reflected by the peritoneal dialysis international publications. If you look at the demographics, they are changing. Most of the publications are coming from Far East, China, Hong Kong, etc., etc. The current PD growth rate in China and India, 20 to 30%. So that's a very robust activity which is keeping it thriving. So far, the PD role models, if we look at, Hong Kong has taken the lead. They have the PD first policy, which is now being replicated by many countries, including Thailand. The PD penetration at present in Hong Kong is 80%. 80% of all the dialysis dependent population, they are on PD. PD is by default. Any patient deemed to require dialysis automatically goes on PD unless you can record a reason that why PD is not suitable for this patient. Only then you can use other modalities such as dialysis, etc. In the Australia, New Zealand peninsula, we are seeing that 20 to 35% of the home population, i.e. 1/3 of them, they are on some form of PD. And of course, to date, the largest population of PD dependent patients, they are in Mexico. I recall a long time back with my mentor, once we traveled to Mexico, Colombia, when they were asking us to come and help us setting up a PD program there. And my mentor, Ram Gokal, he commented that where is the hemo program? And they were told that that's why we want PD, because there's no hemo, we cannot afford it. So he said that to have a viable, successful PD program, you have to have hemo. So these are complementary therapies. You may need to basically, as a result of dropout, stopping one technique, switching over, and complementing, and so on and so forth. They have a large population. Half of that is covered by Social Security. The problems that are occurring there in terms of basically the side effect profile and of course the very high peritonitis rates in Mexico, they are mainly because PD can be practiced by non-nephrologists unlike hemodialysis. So though it increases the access to treatment, but then there are the repercussions, so we have to remain vigilant. Indian experience is very much relevant to us because we started almost sort of in a similar situation. We were about 5 years behind them. In basically mid-90s, they started 3 exchanges a day.